Our next speaker is Dr. Rohan Palshetkar, and he is going to speak on the subject of evaluation of female factors of infertility. I request Dr. Rohan Palshetkar to kindly take the stage.
Good morning, everyone. Firstly, I'd like to thank AMOGS, the chairpersons, and Manjushi ma'am for giving me an opportunity to speak at this wonderful workshop. So my topic for today is workup of an infertile woman. As we know that there's been an increasing trend of infertility which has been on the rise, and even if you look at the increasing trend, we've noticed that the cumulative pregnancy rate through natural conception is still 90%. But the entire thing is, as age is increasing, women are considering more delayed pregnancy because they're looking at their careers. They want to settle down before they consider pregnancy. So because of that, there sometimes is a rising trend. It's not just the woman, it's also even the man who's considering getting married late, even then delaying the pregnancies. And all these factors together are resulting in an increasing trend of infertility. So now, because of this rising trend, we need to work up these patients, and because of which I'm going to be concentrating just on the female aspect of it, and I think Chaitanya sir is going to be talking about the male aspect of it. So when your patient, this is what happens generally at our center. Our patient comes in, initially they go to your front desk, a general quick information about the patient's taken, then they generally go to your clinical associate where they take a detailed history, which I'll be getting to later, and then they come to a consultant. Yes, I put a counselor slide there, but eventually we are the ones who are eventually counseling as consultants, and then they go back to your clinical associate where they are, all the investigations and all the tests which have to be carried out are done. So what is the job of your clinical associate? And if you don't have a clinical associate and you're the only one in your team, first thing what you want to do is check your height, the weight, the BMI and the blood pressure, and take a detailed history. Why is the height, weight, BMI also important? In case you're considering this patient either for a ovulation induction or even for with planned relations or an IUI or an IVF, the BMI is going to be one of the factors which will decide your dosage of the hormones that you're going to be giving the patient. So it's very important that you start with the basic investigations, which include your physical examination. Then when you look at the history, you're going to go through the normal history. As you know, I don't need to go into the details. But my one thing what I want to ask you is make sure that your investigations done in the past are gone through thoroughly. Because the last thing you want to do is increase the burden of cost on the patient. Because if you do repeated examinations, then it's going to result in increased cost for the patient, and then treatment suffers later on because of money issues or anything like that. HSG is one thing which I want to talk to you about a little bit in detail before I go on to the next slide. It's said now that HSG, when you're doing for a patient, if there is no specific history for this patient, where it's suggestive of blocked tubes, you can go ahead with the treatment, and then if there are failed cycles, you can begin doing, you can do an HSG then to confirm whether the tubes are open or not. So then when the patient's coming to you from your consultant's room, from your associate's room to your room, elicit any history sometimes your junior may have missed. Because sometimes they may be in a rush because of your patient load or anything. So ensure that a detailed history is taken. Another thing, a physical examination is very important for the patients, because at the end of the day, if you're suspecting galactorrhea or anything like that, it's important to elicit that. This patient is coming to you, take that advantage of doing an opportunistic screening of a pap smear. Because many times when I have noticed when I'm going to do an IUI or something, I see cervical erosions or something like that, and then I'm like, okay, a pap smear should have been taken initially. So don't miss out on this opportunity, because as we know, it's a little off topic, but cervical cancer is one of the leading cancers of women in India. The next thing what you want to see is a transvaginal ultrasound. This is not only going to give you a clear picture of the ovarian reserve, provided you're doing this on day 2, but it'll also give you a clear-cut picture on whether whether there's a polyp, whether there's a fibroid, how is the uterus tubes. You can add this with an SSG or a HSG if you're doing this at a day 7 or a day 8 if you are thinking of testing the tubes. Another thing with the SSG is it helps you delineate the uterine cavity much better, and smaller polyps which may be missed on a regular sonography could be caught. Ideally, try and do your own sonographies because this will give you a clear-cut picture about what you're going to be suspecting in these patients. Now, when you look at the blood test you want to do, obviously your serology will include the blood group of a patient, your ovarian reserve, the endocrinology aspect, your pre-op virology, and any additional tests which may be required. You can think of doing a trial transfer just to see which way the cavity is going, but it's not something which I do on a regular basis. I don't know how many others do, but it is something which you can consider if you want to think about it. Hysteroscopy, laparoscopy, I'll be getting to it, but it's not a part of your routine investigation. It's more of a advanced investigations after you've ruled out the basic things. Mammography, it's optional, but it's recommended in women above the age of 40 or in women who have a history of breast cancer or ovarian cancer in their family. Now, pre-anesthetic checkup for all. It's compulsory you do your regular tests because especially if you're going to do IVF cycle where a pickup is going to be involved, it's important that you have a clear-cut picture and they're not at any risk for any kidney or liver disease which requires to metabolize the anesthetic drugs. Physician fitness is advisable, especially if a woman is above 40 or she has a high risk for anesthesia. In fact, for every woman above the age of 40, we do include a 2D echo, a pap smear, as well as a mammography in all our cases. Obstetrician fitness should also be considered, especially in women above the age of 40 because they are more predisposed to PIH as well as GDM. Also, women with a previous history of GDM or PIH, you should be getting a fitness, if not from an obstetrician, at least get it from a physician who clears them for a pregnancy. Now, coming down to the main serology, which is your ovarian reserve. So many times you've been doing day 2, day 3 FSH levels and AMH levels. Personally, I don't do day 2 or day 3 FSH levels. It was being done in the past, but now with the AMH, I personally feel it's time to move on to more advanced technologies which are giving you better results. But sometimes because of the expense, we think, okay, let's do a day 2, day 3 FSH levels. But I implore you, please switch to AMH. It's a much better predictor. But speaking about FSH, you generally do it on day 2. FSH and LH levels of more than 10 are generally predictive of a poor ovarian response. One study has shown that a FSH level above 18 IU has shown no live births. Now coming to AMH. AMH actually is a good predictor of your ovarian overall follicle pool. In fact, AMH is something like your HbA1c, your glycosylated hemoglobin. Because your ovarian reserve, the follicles which are to be recruited for this month are selected up to 120 days prior to your cycle. So AMH is a good predictor of the antral follicle count which would be there. It's also a good predictor of PCOS and hyperresponders. In fact, when you're stimulating the patients and you see a high AMH level, you'll be more careful about making sure that the gonadotropin dose you're using is less, or even your oral ovulation you're using, you may consider using a lesser dosage. Because we've seen that sometimes even with a dose of 50 mg of clomiphene citrate, patients can blow up and give you hyperstimulated ovaries. It's been seen that an AMH value of more than 4.85 was considered a cutoff value for predictive OHSS with a sensitivity of 85.7% and a specificity of 89.7%. Now coming to endocrinology. We're looking at the thyroid hormones and prolactin as one of the main factors when we're thinking of infertile patients. So let's talk about thyroid dysfunction. It's generally associated with a luteal phase defect, a failure to sustain an embryo, and early pregnancy loss. Hypothyroidism can cause anovulation and menorrhagia, and it can even cause oligomenorrhea. Graves' disease has an increased risk of spontaneous abortion. So when we're looking at thyroid hormones, we're generally looking at a TSH value of 2.5 or less. A TSH, prolactin, and GH generally act synergistically with FSH to induce oocyte growth. and almost 50% of your patients who have hypothyroidism could have hyperprolactinemia as well. So it's something that you should keep an eye on especially. But I think as a routine investigations, all of us are doing our thyroid profile as well as the prolactin levels. So I think we're able to catch these things pretty easily. An ASRM paper which was released talked about hypothyroidism, or rather subclinical hypothyroidism in an infertile patient. It showed that there's insufficient evidence for subclinical hypothyroidism. That's TSH of more than 2.5 with a normal free T4 level. That whether that is associated with infertility. But when you're talking about autoimmune thyroiditis where the TSH value is more than 2.5, for them levothyroxine is necessary to be started to maintain a level below 2.5. When I'm talking about prolactinemia, you're talking about decreased ovulation, reduced fecundability. I'm just going to rush through because I'm looking at the timer, which is cutting me a little short. But when we're looking at it, just remember that sometimes you may have a prolactin value of, say, if your lab is saying a 25 cutoff and your prolactin level say about 28, 30, don't immediately start off on your cabergoline or anything like that. Because sometimes just a venopuncture could increase your prolactin levels. Doing a prolactin level is said generally to be done between, say, 8:30 to 9:30, because that's a little bit stable at that time and in a fasting level. If you're doing it, there's a varying rhythm of prolactin occurring throughout the day. So that's another thing which you have to consider. So if your prolactin levels are just above the normal, think of doing a repeat level again for that patient. If your prolactin levels are above 100, think about doing an MRI because it could be a micro or macro prolactinemia. If you have continuously raised levels on a repeated dose, again consider doing imaging. And less than 10% of the hyperprolactinemia patients have been shown to see prolactinomas. Your most frequent cause is drugs. So just make sure that whatever drugs are being used, you have an idea which of them is actually causing hyperprolactinemia. So those can be changed and an alternative treatment could be started. I've already spoken about the pre-op workups. Viral markers, obviously you need to do them not only for your safety, but also if you're taking out your oocytes and you're planning to freeze your embryos or anything like that, you have to ensure that you have a different container for the patients who could be seropositive. Again, rubella IgG is something we do because we want to ensure that your patients which are there are protected against rubella. So positive rubella IgG means that your patient has been vaccinated and she is protected against rubella. HB electrophoresis is something which we do in all our women patients because we want to rule out your thalassemia as well as sickle cell, which could be there. Vitamin D3, again, we know that most of the women are deficient, not just women, the men as well. The last 4 tests or 5 tests is something what we do in recurrent implantation failures or in patients with bad obstetric history. So that's something you can consider at that point. Now in hysteroscopy, when you're considering 10% of your cases, a uterine pathology can be found where the HSG and SSG have been normal. In our study, we have a study of over 5,000 hysteroscopies which have been done by Dr. Nandita as well as Dr. Rishikesh, where we have seen a 14.7% abnormality in the uterine cavity. Let it be a polyp, let it be a fibroid, a septum. I'll just take another minute. I should finish in 1 minute. As per the NICE guidelines, it's been said that hysteroscopy should not be offered routinely, but only in indicated cases. So this was just a bubble test, which I just wanted to show what we do, where you can just see your tubal patency, where you can see the bubbles are just passing through the ostia. You'll see on the other side as well. It's just an air bubble pushed through the saline, where you can, if the air bubbles pass through the ostia, you can take it for granted that the uterine, the fallopian tubes are open. In that sense, you're avoiding a laparoscopy for a patient where there's no pathology where you're suspecting in the pelvis itself, and you just wanted to do a plain hysteroscopy. A laparoscopy as a part of a regular fertility assessment is still a debate and dilemma for all gynacs. It should be considered in patients who have undergone empirical treatment or 2 to 3 IUI cycles for unexplained infertility. This would actually help us decide the future treatment, because sometimes mild or minimal endometriosis may be missed, and this could help convert our treatment from a normal oral ovulation cycle to maybe a gonadotropin stimulated IUI cycle. And HL-scopy should be considered in women over the age of 35 with unexplained infertility when deciding to choose the line of treatment. Women with hydrosalpinges should be offered salpingectomy, preferably by laparoscopy, because IVF treatment rates do improve, and the live birth rates will also improve if the salpingectomy is done. So remember one thing: well begun is half done. So if you have a good thorough history, a good thorough investigation done, half your work is ready, and therefore when you're stimulating your patients or trying whatever treatment, it will definitely make it easier for you. Thank you.